Hi, I'm Francis Zhang. I'm a neuroradiologist and radiopedia editor. Today we're going to talk about cerebral small vessel diseases. This is both a common and important entity. It's one of the most common causes of stroke as well as cognitive impairment in older adults. You may have come across the phrase small vessel disease in your first rotation in radiology residency because it's nearly ubiquitous. Those nonspecific white matter hyperintensities or hypodensities commonly related to small vessel disease. So what is that really? What does it mean? And what are the manifestations of small vessel disease? So that's what we're going to talk about today. The first thing is we're going to try to have you describe the imaging manifestations of small vessel disease using a standardized nomenclature. What you'll learn is it's more than just the white matter hyperintensities. You'll also be able to distinguish the major types of cerebral small vessel disease. It's not just the old age-related, vascular risk factor-related, hypertension-related small vessel disease. There's more than that. The main two sporadic types of small vessel disease are the arteriolosclerosis or hypertension-related arteriopathy, and cerebral amyloid angiopathy, which is also quite common. We're also going to talk about some uncommon small vessel diseases, namely the hereditary or genetic small vessel diseases, inflammatory or immune-mediated small vessel diseases, as well as a miscellaneous category that includes radiation-related arteriopathy. So what is a small vessel? You may know of the large and medium vessels from the stroke world. Large vessels, for instance, are the intracranial internal carotid artery and the middle cerebral artery M1 segment. So when you have a large vessel occlusion, you can perform a thrombectomy. The middle medium vessels are those that are slightly smaller, like the M2 or M3 segment of the middle cerebral arteries. The small vessels are even smaller than that, okay? So in general, any vessel that has perforated into the brain parenchyma is considered a small vessel, as well as those still on the leptomeningeal surface of the brain that are smaller than about half a millimeter. Now, this small vessel definition includes small arteries, arterioles, as well as capillaries and venules. The latter two don't get very much attention in the research literature, so what we're going to focus on today is what we mostly know from the research literature on disease of the small arteries and arterioles. Now, what this means for radiologists is that small vessels are not discretely visible by imaging. We can't identify that, oh, there's an occlusion of this small vessel, at least not with current imaging technology in live patients. So what we have to rely on are markers of small vessel disease, the sequelae of disease of these small vessels. There are different distributions of small vessels in the brain. The first type are the deep small vessels, which, like the lenticulostriate arteries that arise directly from the large vessels, these irrigate the deep cerebral brain matter, including the deep gray nuclei and the internal capsule. And then the medium vessels give rise to the small vessels over the cerebral surface that then perforate the cortex and subcortical white matter. And these are the superficial small vessels, and these meet in the junctional zone or border zone around the periventricular white matter, which is a common area of the sequelae of small vessel disease. Now, what are the markers of small vessel disease? There are a number of markers that have been defined in a standardized manner, and these are recent small subcortical infarct, lacunae of presumed vascular origin, a white matter hyperintensity of presumed vascular origin, perivascular spaces, cerebral microbleeds, spontaneous intracerebral hemorrhage, cortical superficial siderosis, and brain atrophy. I mention these markers specifically because they were raised by a consensus working group known as the STRIVE group that was led by a neuroradiologist, Joanna Wardlaw, as well as a multidisciplinary group of experts on the standardized reporting of imaging changes related to small vessel disease. Our first marker is a recent small subcortical infarct. This refers to a diffusion restricting area that is generally less than 20 millimeters in diameter on axial images. Subcortical means it affects the deep gray nuclei, the white matter, or the brainstem. It spares the cerebral cortex. These are due to ischemia that occurred within the past few weeks based on either clinical or imaging criteria. in the territory of one perforating arteriole. Larger than that, it wouldn't be a small subcortical infarct. Now, many of you would have called these a lacunar infarct, but the STRIVE working group specifically avoided that term because these small, recent subcortical infarcts do not always become lacunes. Often they do. Often they cavitate and become lacunes, which is our next term that we'll talk about. But sometimes they evolve and become flare hyperintense. Sometimes they evolve and become nearly invisible on follow-up MRI. And that's the reason they avoided the term calling these lacunar infarcts. A lacune of presumed vascular origin is a round or ovoid fluid-filled space. It follows CSF signal intensity. It's 3 to 15 millimeters in size. It's subcortical, meaning sparing the cerebral cortex. And it is most commonly due to a prior small subcortical infarct. However, they did not call these lacunar infarcts per se because some of these lacunes were also due to old, deep hemorrhages that have since cleared of the hemorrhagic components. So the term lacune is agnostic to whether the initiating event was ischemic or hemorrhagic, or perhaps ischemic with hemorrhagic transformation. So it is purely a descriptive imaging finding of a lacune. A white matter hyperintensity of presumed vascular origin refers to a T2 or flare hyperintensity that, in the context of small vessel disease, as opposed to demyelinating or infectious or trauma disease, it can be a variable size. It's located within the cerebral white matter, and it is not cavitated. So this appears hyperintense on flare, but then you look on your T2, it's not quite CSF signal intensity. And this is due to fluid or protein leakage into the interstitium around vessels. It is due to myelin loss, axonal loss, gliosis. The neuropathology is actually quite varied, and our understanding of white matter hyperintensities is incomplete. But to the best of our knowledge, this is a process that occurs due to small vessel disease around the perivascular spaces and around venules as well. When it comes to reporting white matter hyperintensities, people recommend reporting a grade of severity of these white matter hyperintensities. The most commonly used grading scale in research and in clinical practice, there are many, but the most common one is the Physicus scale. Now, as originally described, there were two components of the Physicus scale. One described the periventricular white matter, one described the deep white matter. With further research, it became apparent that really only the deep white matter rating scale was correlated with other markers of small vessel disease. And so that's what we refer to when we refer to the Physicus scale not otherwise specified. We refer to the deep white matter rating scale. So what this entails is a grade 1 refers to punctate scattered white matter hyperintensities in the subcortical and deep white matter. Grade 2 are beginning confluence, these larger areas of patchy white matter hyperintensities. And then grade 3 are large confluent areas. These are so large that you can trace them from one region to another if you're scrolling up and down. An analogous term on CT is white matter hypodensity or hypoattenuation. You can make this finding, however, it is somewhat less reliable because the difference between what is a white matter hypodensity versus normal white matter is just somewhat less apparent than it is on MRI. But you can still make the analogous ratings. So in general, I try to rate the severity of white matter hypodensities much in the same way I would rate them for white matter hyperintensities on MRI as mild and punctate, moderate and patchy, and severe and confluent. The STRIVE group noted that commonly in small vessel diseases, you also have T2 hyperintensities in non-white matter areas, such as the thalamus or the brainstem. And so these were grouped in an umbrella term of subcortical hyperintensities. So that includes white matter, that includes deep gray nuclei, and that includes the brainstem. And this is an example of a pontine T2 hyperintensity, both on flare and on T2. Our next marker of cerebral small vessel disease is perivascular spaces. So these are punctate or linear fluid-filled spaces that are less than 3 millimeters in diameter. They're punctate if they're coming out of the plane of imaging. They're linear if they're coursing within the plane of imaging. They're subcortical, meaning not involving the cortex, and they can be located in either the basal ganglia, as in this case, or in the centrum semi-ovale, in the subcortical white matter. Now, you'll notice that the imaging characteristics are that they're T2 hyperintense, and they will not be apparent on FLAIR because the fluid signal will suppress. Now, these are pathologic when they're numerous and dilated meaning they're visible on MRI. And this is due to impaired drainage of the fluid around arterioles, attributed to some dysfunction of the blood-brain barrier of the small vessels. Now we're going to move on to hemorrhagic features of small vessel disease. The first is cerebral microbleeds. These are round hypointensities on T2 star gradient echo, or even better, with more sensitivity, SWI, susceptibility weighted imaging. These are generally 2 to 5 millimeters in size, but with better imaging, with SWI at higher field, 3 Tesla or higher, these can bloom up to 10 millimeters. They're generally not visible on other sequences. On occasion, you can see them, but they're very hard to see on T2 weighted images, for instance. These represent collections of hemosiderin-laden macrophages that have cleaned up a prior bleed, a prior leakage of a small number of red blood cells into the interstitium around these small vessels. These can be lobar in location, meaning at the cortical or subcortical regions, or they can be deep. Here are a few cerebral microbleeds in the putamen and thalamus. Contrast that to macrobleeds, which are known as spontaneous intracerebral hemorrhage, presumed to be due to small vessel disease. These are intraparenchymal hematomas, which should be visible on more than just your SWI. We can see it here in the paramedian right frontal lobe on CT, on T1 and T2, as well as on SWI. When we say there's spontaneous intracerebral hemorrhage, we mean there's no obvious secondary cause, such as antecedent head trauma. There's no underlying vascular malformation or a hemorrhagic tumor or hemorrhagic transformation of a territorial infarct. So those have to be excluded before you call something a spontaneous intracerebral hemorrhage. These can happen in the deep brain as well. Here's an example occurring in the right basal ganglia. Our next marker is cortical superficial siderosis, sometimes known as superficial cortical siderosis. These are linear rather than punctate hypointensities on GRE and SWI. These happen over the cerebral convexities, and that is in contrast to the classic superficial siderosis that occurs in the infratentorial compartment that presents with hearing loss and so forth. We're talking about over the cerebral convexities and in the sulci. These occur without having subarachnoid flare hyperintensity or CT hyperdensity, and that's to contrast it with acute subarachnoid hemorrhage, which will be our next slide. And what superficial siderosis represents is chronic blood products that have deposited into the superficial subpial layers of the cerebral cortex or are still residing within the subarachnoid space. There used to be a term of subarachnoid siderosis that referred to blood products in the subarachnoid space, but because it has much the same pathophysiology as superficial siderosis, it has been subsumed under the umbrella term of superficial siderosis to mean either blood in the subpial cortical layer or in the subarachnoid space. And so what this appears as on imaging is this hypointensity either creating a tram track appearance outlining the cerebral cortex or filling the entire sulcus, especially if there's not much cerebral atrophy. Contrast that with a related term, also a marker of small vessel disease, is acute convexity subarachnoid hemorrhage. So again, on SWI, this will appear as a linear hypointensity, but on FLAIR, there will be hyperintensity of the fluid in that sulcus. And if you had a CT available, it should appear hyperattenuating. And so this is the presumed precursor to all cortical superficial siderosis. I will note, however, that not all subarachnoid hemorrhage evolves into superficial siderosis, and we don't exactly know why. Now let's review the focal markers of cerebral small vessel disease. First, there are recent small subcortical infarcts. There are lacunes, which are the chronic manifestation of a prior small subcortical infarct or hemorrhage. There are white matter hyperintensities, some of which used to be infarcts, many of which developed on a chronic basis due to dysfunction of the blood-brain barrier of these small vessels, causing leakage of fluid and protein and myelin loss and gliosis. Perivascular spaces, which are considered pathologic when enlarged and too numerous. And then the hemorrhagic markers, cerebral microbleeds, which are microhemorrhages that can occur in the basal ganglia, the brainstem, as well as lobar locations. Intracerebral hemorrhage, which is spontaneous when not attributed to another cause like trauma. And then cortical superficial siderosis and convexity subarachnoid hemorrhage are also considered small vessel disease markers. Now, I want to end this section by stating one more marker of small vessel disease that the STRIVE working group wanted to highlight, and that is brain atrophy. They define brain atrophy as lower brain volume unrelated to a macroscopic focal injury such as trauma or an infarct. So in other words, this is a generalized parenchymal volume loss process. And they want to highlight this as a marker of small vessel disease because it is what mediates the relationship between small vessel disease and impaired cognition. I think of it as the common final pathway for a number of neurodegenerative disorders as well as small vessel disease impacting cognition. Now, with the markers out of the way, let's talk about the types of cerebral small vessel disease. I told you the two main types of sporadic cerebral small vessel disease are arteriolosclerosis and CAA. So type 1, also known as hypertensive arteriopathy, is most commonly related to arterial hypertension and traditional vascular risk factors such as smoking, diabetes, and advanced age. Not everyone is hypertensive, but most people are. The main finding with hypertensive arteriopathy are subcortical infarcts and, in the chronic phase, lacunes. You can have hemorrhages as well, and these are mostly, but not exclusively, in the deep brain. In the basal ganglia, the thalami, and the brainstem, you can have cerebral microbleeds as well as presentations of intracerebral hemorrhage. You get dilated perivascular spaces in this disorder, predominantly in the basal ganglia, and you have deep cerebral white matter hyperintensities and eventually brain atrophy. Now, cerebral amyloid angiopathy, or CAA, is an amyloid beta deposition disease. So beta amyloid protein deposits in the walls of small arteries, arterioles, and occasionally even capillaries. It causes fragility to these vessels. They can occlude as well as rupture. You can see cortical microinfarcts on autopsy. They're very hard to see in vivo because of their small size. People have reported seeing cortical microinfarcts associated with CAA on high field MRI, at least 3T, and more commonly at 7 Tesla, that are attributable to disease of the small perforating cortical arteries that are affected by CAA. What is a more important feature in CAA to understand, though, are the hemorrhagic features. And these are consisting of only lobar, meaning cortical or subcortical region, cerebral microbleeds, or intracerebral hemorrhages. In addition, you get cortical superficial siderosis or convexity subarachnoid hemorrhage in CAA. You can also see dilated perivascular spaces, and these are predominantly in the centrum seminal valley. Do you see the pattern here? So arteriolosclerosis affects the deep brain predominantly, and CAA affects the lobar brain predominantly in the cortical subcortical region. In both these disorders, you get white matter hyperintensities, which are nonspecific, and eventually develop brain atrophy. Now, let's take a look at an example. Here's an 85-year-old female who presented with a history of dementia and left-sided weakness before, but now they have worsening left-sided weakness. On DWI, we see evidence of a recent small subcortical infarct here in the corona radiata, extending into the posterior limb of internal capsule that would explain their focal neurologic deficit. On T2 weighted imaging, we see these fluid signal intensity cavities. These are lacunes in the periventricular white matter in the basal ganglia region, as well as the centrum seminal valley. On FLAIR, we see confluent, severe white matter hyperintensity. We would call this Fazekas grade 3. There are also subcortical hyperintensities that involve the brainstem, here in the pons, and here in the thalami as well. On SWI, we see numerous cerebral microbleeds in the deep brain involving the thalamus, as well as the midbrain and pons. In addition, there are a number of cortical or subcortical cerebral microbleeds, but we would not conclude from this that they have some component of cerebral amyloid angiopathy, because they also have the deep brain hemorrhages and all the other manifestations of hypertensive arteriopathy. Here's another case. 50-year-old male presented with progressive dementia and right-sided weakness. Here too, they have a recent subcortical infarct that's small in the centrum seminal valley. On FLAIR, we see a few white matter hyperintensities here and there. But the main findings are really going to be on the SWI. And you got to look closely because these findings are small. And these are a number of cortical, subcortical, cerebral microbleeds. And these are strictly lobar, meaning there are none seen in the deep gray nuclei. There are none in the brainstem. So this was a pathology-proven case of cerebral amyloid angiopathy. So how do we diagnose cerebral amyloid angiopathy without pathology? There are diagnostic criteria, most recently updated last year as the Boston 2.0 criteria. And we're going to talk about the category of certainty called probable CAA, which is the category that you can make on the basis of clinical and radiologic findings without pathology. To meet probable CAA criteria, you have to be aged 50 or more. You have to present with either spontaneous intracerebral hemorrhage, transient focal neurologic episodes, or cognitive impairment or dementia. On imaging, you have to have 2 strictly lobar hemorrhagic lesions or 1 lobar hemorrhagic lesion plus a white matter feature. I'll note that these white matter features are new to the 2.0 criteria, and you may be familiar with the older criteria that did not have white matter features. So what are these hemorrhagic lesions? You can have cerebral microbleeds, intracerebral hemorrhage, cortical superficial siderosis, or convexity subarachnoid hemorrhage. You can have 2 in any combination. You can have 2 cerebral microbleeds to meet these criteria, or you can have 1 cerebral microbleed and 1 sulcus of cortical superficial siderosis. Or you can have 1 lobar hemorrhagic lesion plus a white matter feature, and the white matter features are white matter hyperintensities and a multi-spot pattern, or what they call a multi-spot pattern. I think of either scattered or patchy. Or you can have severe perivascular spaces, meaning more than 20 MRI visible perivascular spaces located in the centrum seminal valley. Now, there are important exclusion criteria to probable CAA. You cannot have any deep hemorrhages. That would be in the brainstem or in the deep gray nuclei. You could have hemorrhages in the cerebellum, but they don't count for either lobar or deep. And you have to exclude other hemorrhage causes. So other hemorrhage causes might be they've had a history of open heart surgery, they went on cardiopulmonary bypass and anticoagulation, and you can commonly see cerebral microbleeds related to that. They may have had prior head trauma. You can get diffuse axonal injury, which can appear as cerebral microbleeds, as well as FLAIR hyperintensities. You could have a hemorrhagic transformation of a territorial infarct and have a hemorrhage. You can have a arteriovenous malformation that ruptured and that presented with intracerebral hemorrhage. So these will all have to be excluded before you conclude somebody had probable cerebral amyloid angiopathy. But it's remarkable that based on just these clinical and imaging features, you can make a good guess that somebody has probable cerebral amyloid angiopathy. Now, I want to go over 2 severity rating scales for these sporadic cerebral small vessel diseases. I don't want you to memorize these severity rating scales or necessarily even apply them in your clinical reports. I do want you to pay attention to, however, what research teams have found to be relevant in studying because they correlate with either risk factors for cerebral small vessel disease or with outcomes of cerebral small vessel disease like a symptomatic infarct or intracerebral hemorrhage down the line. Now, in type 1 cerebral small vessel disease, i.e. arteriolosclerosis, there's something called the total SVD score, small vessel disease score. It's a 4-point scale. You get a point if you have any lacunes. You get a point if you have any cerebral microbleeds. These can be deep or lobar. You get a point if you have more than 10 perivascular spaces visible in the basal ganglia of one side. And you get a point if you have moderate or severe deep white matter hyperintensities, which were defined by these groups as physicas grade 2 or 3 in the deep white matter, or something I didn't tell you about, grade 3 in the physicas periventricular white matter scale, but that really refers to periventricular hyperintensities that extend all the way into the deep white matter. So I think of it in my mind as a lot of deep white matter hyperintensity gives you a point on these scales. Now, there's also a scale for the severity of cerebral amyloid angiopathy. If you have cerebral microbleeds, that number 2 to 4 in total, you get a point. If you have more than 5 cerebral microbleeds, you get 2 points. If you have what they call focal superficial siderosis, meaning affecting 3 or fewer sulci in the cerebral convexities, you get a point. If you have disseminated superficial siderosis, you get 2 points. That is affecting more than 3 sulci. You get a point if you have more than 20 perivascular spaces visible in the centrum seminal valley. So keep that number in mind when you kind of eyeball somebody's T2 weighted imaging on brain MRI. Does this person have a lot or a little dilated perivascular spaces? Do you think there are more than 20, or do I think there are only a few here and there? And then finally, also in the CEA severity scale are the moderate and severe deep white matter hyperintensities. So that's a feature of both. So let's take a look at some example cases, because what the severity grading scales are intending to predict are sequelae like intracerebral hemorrhage. This was a 30-year-old male who was a known young hypertensive since they were a child, who presented with acute onset left-sided weakness. And unfortunately, they had intracerebral hemorrhage on the right cerebral hemisphere that would account for their focal neurologic deficit. And as to why, we can see the background of sequelae of prior small vessel disease. We can see a lacune in the right part of the pons here. We can see lacunes in the basal ganglia, and we can see confluent white matter hyperintensities. That would be physicas grade 3 here. And on SWI, we see the hemorrhage, but we also see sequelae of prior hemorrhages. This larger area looks like a prior intracerebral hemorrhage, and then there are these scattered areas of cerebral microbleeds. So this would be at the very severe end of hypertensive small vessel disease. Here's another case of an 80-year-old male who woke up with right arm weakness. Unfortunately, they too had intracerebral hemorrhage. Now, to distinguish the etiologies, we obtain an MRI, and that redemonstrates the intracerebral hemorrhage, but also shows superficial siderosis in the ipsilateral cerebral hemisphere. And what we also see are the cerebral microbleeds in cortical, subcortical regions. Importantly, there are no cerebral microbleeds in the deep gray nuclei or the brainstem. On the T2 weighted images, we don't see any lacunes. We may see some white matter hyperintensities. We see edema around this hematoma. But this ended up to be a pathology-proven case of cerebral amyloid angiopathy. And this would be at the moderate to severe end of cerebral amyloid angiopathy. Let's take a look at a companion condition, one I haven't mentioned before. So this was a 75-year-old female who had an unwitnessed fall. They have these white matter hyperintensities, but they're a little bit unusual from the ones I've been showing you so far. These seem to have some mass effect in the periorlandic region. This precentral gyrus looks expanded. So there's some component of vasogenic edema happening here. The SWI reveals numerous cerebral microbleeds in strictly lobar locations. There are none in the deep gray nuclei, and there are none in the brainstem. Now, there are some in the cerebellum, but they count neither here nor there in the Boston criteria. But we would conclude that this patient has probable cerebral amyloid angiopathy. But putting that together with this area of periorlandic vasogenic edema coming into the occipital lobes, there are also some asymmetric areas affecting the frontal lobes, we would conclude this person has inflammatory cerebral amyloid angiopathy, specifically the subtype called probable cerebral amyloid angiopathy related inflammation. These have specific diagnostic criteria. You have to be age 40 or more. You have to be presenting with headache, decreased consciousness, behavioral change, or focal neurologic signs and seizures not attributable to an intracerebral hemorrhage. The main imaging criteria are asymmetric white matter hyperintensities that extend all the way to the immediately subcortical white matter, and lobar hemorrhagic lesions that probably otherwise fit the diagnostic criteria for CAA alone, such as cerebral microbleeds, intracerebral hemorrhage, and corticosuperficial siderosis. And you have to exclude other causes of white matter hyperintensities and hemorrhage. But our case was a case of probable CAA-related inflammation, also known as CARI, and that was treated with anti-inflammatory medical therapy. Now, I want to transition to a group of uncommon cerebral small vessel diseases. These include inherited and genetic small vessel disease, inflammatory and autoimmune small vessel disease, as well as miscellaneous, including post-radiation angiopathy. Our first case was a younger person who had brain imaging because of headache, and they have these white matter hyperintensities that are at least Physicus grade 2, if not 3, because of their confluence. But what's unusual about this pattern is that there was also white matter hyperintensity of the subcortical white matter of anterior temporal lobes bilaterally. We can also note that on SWI, there are a number of deep cerebral microbleeds involving the thalami and the brainstem as well. This turned out to be a case of CADASIL. So CADASIL is an acronym for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It is the most common hereditary cerebral small vessel disease. There are a number of others, but they're less common than CADASIL. CADASIL features nonspecific imaging features that you would see in many other small vessel diseases like lacunes, white matter hyperintensities, and even cerebral microbleeds. One feature that has been described as more specific is white matter hyperintensities in the temporal polar regions, that is, the anterior temporal lobes going all the way to the subcortical U fibers. Now, it's not 100% specific, and because of how rare CADASIL is, I've seen CADASIL been raised in radiology reports, and then it panned out not to be CADASIL. But it is still important nonetheless for us to raise that possibility. The diagnosis is established either by skin biopsy or genetic testing. The skin biopsy reveals pathologic change in the small vessels of the skin that are analogous to the small vessel changes in the brain. The genetic test is for a gene called Notch3, which is important because it encodes a protein that regulates and maintains the vascular smooth muscle of small vessels. Our next entity will start off with a case of a 40-year-old male who presented with right motor and sensory cortical epilepsy for 1 day. On the FLAIR images, we see some nonspecific white matter hyperintensities in the cerebral hemispheres. There is also an intracerebral hemorrhage in the right frontal lobe. You can see that hemorrhage and many more on this SWI minimal intensity projection image, primarily in the frontal lobes, and these are numerous cerebral microbleeds and larger ones that would probably be best called old intracerebral hemorrhages. MRA was performed, which did not reveal any abnormality of the visible vessels, but remember that small vessels are not visible by MRA, so a normal MRA does not exclude small vessel disease. The very important sequence that was performed here was a so-called vessel wall imaging, which is a T1-weighted post-contrast black blood technique that is intended to identify inflammation in the medium and large vessels. But what this sequence is also useful for is identifying parenchymal inflammation without the kind of confounding of normal vascular enhancement, because flowing blood in the vessels will appear black on this sequence. And what we see, excluding that hematoma, is that there are these linear areas of contrast enhancement. These seem to follow cell size, so those would be leptomeningeal, but some of these areas are very wispy, come down deep into the brain parenchyma, and so these would be intraparenchymal. These have a radiating pattern to them, radially oriented pattern that's suggestive of a vascular distribution, and this is suggestive of what this turned out to be, CNS vasculitis. So CNS vasculitis can be divided into two categories. One is primary angiitis of the central nervous system. And so these are vasculitides that are localized to the brain and occasionally spinal cord and not affecting other organs. Secondary CNS vasculitis refers to when you have inflammation of the vessels in the central nervous system, but also systemic involvement. It can either be due to infection or systemic vasculitis, such as the ANCA-associated vasculitides, such as granulomatosis with polyangiitis, formerly known as Wegener's, eosinophilic granulomatosis with polyangiitis, also known as Church-Strauss, as well as the vasculitides that affect vessels of variable sizes, such as Behçet syndrome. And these amount to an inflammation of the medium and or small vessels. It can be very difficult to diagnose small vessel vasculitis because, remember, you don't see the changes on angiography, either MR angiography or even digital subtraction angiography. So what you have to rely on are the secondary changes to the brain parenchyma or the leptomeninges. You can see a number of nonspecific features like multifocal infarcts, hemorrhages, or white matter hyperintensities. A slightly more specific feature is if you see contrast enhancement, either of the leptomeninges or of the brain parenchyma. If your small vessel CNS vasculitis also involves the medium vessels, then you're lucky and you might be able to see vascular regularity or wall enhancement on vessel wall MRI if those medium vessels are involved. Now, as I said, the diagnosis is difficult. First, you have to ask on a systemic workup, is there any evidence of a systemic vasculitis or of an infection? You might opt to treat empirically. You assume the imaging findings are due to inflammatory disorder and you treat with steroids or other immunomodulating therapies and see if the disorder gets better. But the gold standard to diagnosis of small vessel CNS vasculitis is going to be a biopsy of the brain and leptomeninges. So let's take a look at a related case. This is a 75-year-old male who had altered mental status and progressive functional and cognitive decline over 1 month, so on the subacute scale. On DWI, we see multiple small subcortical infarcts, predominantly in a lobar location. And when we saw this, we raised the possibility of cardioembolic phenomenon, but a cardiac workup was unrevealing. Second on your differential would be a CNS vasculitis that is affecting multiple vascular territories. On FLAIR, we see non-suppression of the fluid signal in the sulci, and that can either be due to proteinaceous content, inflammation, or due to subarachnoid hemorrhage. On SWI, this is a minimal intensity projection image. We see in that some of the sulci, there is hypointensity, confirming our suspicion that some of that sulcal FLAIR hyperintensity was subarachnoid hemorrhage. In addition, there are a number of punctate hypointensities on this SWI that, if you looked at the thinner images, would be confirmed to be parenchymal. So there are cerebral microbleeds in addition to the subarachnoid hemorrhage that we saw in this case. And these are strictly in a lobar location. There were none in the deep gray nuclei and brainstem. On post-contrast T1, we saw areas of enhancement as well. So this was in the leptomeninges, kind of outlining sulcus, and this larger area was presumed to be cortical. And so there were multiple of these areas. They were very subtle. You have to look kind of closely, but there's just too much enhancement in some of these sulci to be normal vessels. So we call this leptomeningeal enhancement and raise the possibility of a vasculitis. Now, because we could not satisfy the criteria for CAA-related inflammation, the patient went on to obtain a biopsy, and this was confirmed to be a case of ABRA, amyloid beta related angiitis. This is a special subtype of primary angiitis of the CNS that is associated with cerebral amyloid angiopathy. What this amounts to is not only do you have beta amyloid deposition within the vessel wall, but then you also have an inflammatory response around that beta amyloid within the vessel wall. The imaging features overlap a lot with CAA-related inflammation, CAA-RI, but it has been reported that leptomeningeal enhancement is a little bit more common in ABRA, in amyloid beta-related angiitis. So keep that in your differential toolbox when you're seeing vasculitic changes like leptomeningeal and parenchymal enhancement, as well as a profusion of microhemorrhages that raises the possibility of cerebral amyloid angiopathy. How do we distinguish these different subtypes of the cerebral amyloid vasculopathies? So we have run-of-the-mill sporadic CAA. It's very common in older adults. You have amyloid beta deposition in vessel walls. Those can thicken and cause occlusion of these small vessels, but you can also have leakiness and microhemorrhages around these affected vessels. Then there's the category of inflammatory CAA, which includes CAA-RI and ABRA. So CAA-related inflammation is a perivasculitis phenomenon where you have inflammation around the affected vessels, and that can create vasogenic edema, and that would satisfy the diagnostic criteria of probable CAA-RI that I mentioned. On the other hand, you have ABRA, which is amyloid beta-related angiitis, is where the inflammation, the inflammatory infiltrate is in the vessel wall itself. This too can cause vasogenic edema and hemorrhage, but on pathology, the inflammation is localized to the vessel wall. So this is a true vasculitis. Now, I want to move on to one last entity to round out our talk. This is exemplified by a case of a 40-year-old male who had a history of medulloblastoma, had a resection 20 years ago in radiotherapy. They're asymptomatic now. They had head imaging for surveillance reasons or some other non-related complaint. And what we see are post-surgical changes in the posterior fossa at the vermis. But in the supratentorial brain, we see numerous cerebral microbleeds in the periventricular and deep white matter here. And then here, a larger blooming focus that we can see on T2 weighted images that may be a cavernous malformation. So that was a case of radiation-related microangiopathy. Let's take another example here. This is a 60-year-old male. They had symptoms of progressive brainstem dysfunction. They had a history of nasopharyngeal carcinoma that was treated 15 years ago. Now, I want you to notice the different distribution of cerebral microbleeds in this case. So remember, they had nasopharyngeal cancer, and these microbleeds are predominantly located in the cerebellum and the brainstem, and a little bit in the anterior temporal lobes, but relatively sparing other parts of the cerebrum. There's a few here and there, but that has to do with the amount of radiation that is directed at the brain parenchyma. What is collateral damage is what you often see affected by these cerebral microbleeds. When severe, you can also have ischemic sequelae. On the T2 weighted image, you see lacunes in the brainstem and a lacune in the thalamus as well. So because of the history of radiation treatment, these cases were ascribed to radiation angiopathy. The main feature are cerebral microbleeds within the radiated field, especially in the higher dose range greater than 30 gray. There's usually somewhat of a latency to the appearance of these manifestations, on average 2 to 3 years, but it can be highly variable, and they tend to be regional. In this case, there was a left-sided cerebral hemisphere glioma that was irradiated, and so they have this asymmetry of cerebral microbleeds in the left cerebral hemisphere afterwards. That brings us to the end of our talk. I want to give you a few take-home points. First is that there are markers of cerebral small vessel diseases, and that these include a spectrum of findings, both acute and chronic, both ischemic and hemorrhagic sequelae. It's not just white matter hyperintensities. Number two, there are multiple different types of small vessel disease. The main sporadic types you should know about are arteriolosclerosis or hypertensive arteriopathy and CAA, cerebral amyloid angiopathy. CAA is diagnosed by defined criteria. Look up the Boston criteria version 2.0 that includes both hemorrhagic and white matter features. Finally, uncommon etiologies that we should keep in the back of our mind include the genetic small vessel diseases like CADASIL, the vasculitides, especially primary angiitis of the CNS, but as well as amyloid beta related angiitis in patients who have CAA, and post-radiation arteriopathy, which manifests as cerebral microbleeds. It's very important to have the clinical history of prior radiation treatment to make this diagnosis. Thank you so much for listening to my talk. Stay tuned to hear Rohit Sharma, a neurology registrar and Radiopedia editorial board member, talk about the clinical perspective on cerebral small vessel disease. Thanks.
Thank you, Francis. And hello, I'm Rohit Sharma, one of the neurology registrars in Melbourne, Australia. And I thought I would present a report reader's perspective on cerebral small vessel diseases, really enhancing some of the points that Francis has already brilliantly made. And so I guess really to incorporate what a report reader's perspective is all about is to look at what's not a helpful report. I see these reports, unfortunately, all the time. And for example, here we have a 35-year-old female with recurrent headaches and a recent episode of a focal neurological disturbance with no significant past medical history, and the clinician has asked for the cause. And this report conclusion is certainly not incorrect, but it's probably not something that a clinician such as myself would find particularly useful. So this conclusion states that there are multiple foci of non-specific T2 flare white matter hyperintensities, and states a very broad differential, including demyelination, vasculitis, neurosarcoidosis, cerebral small vessel disease, migraine, infection, toxic and metabolic causes, and then ends with the famous line of clinical correlation is advised, which is which is something we always find very amusing. So what I hope to impart from my part of the talk is two real main objectives. So what the clinician wants from a radiology report regarding cerebral small vessel diseases, and in particular a focus on those white matter hyperintensities, and are they actually due to cerebral small vessel disease? And the second objective is to address what clues may there be on the clinical history which may be relevant to the reporting of cerebral small vessel diseases, and in particular focusing on the patient with a clinical history of an apparent transient ischemic attack, and also the patient with a clinical history of migraine, and thinking about monogenic small vessel diseases in this clinical context. So what do I look for in a report? Well, first of all, in regards to small vessel disease, I want to know whether it actually is small vessel disease or not. And if it's not, then what is it? What am I looking at? And if it is, then how severe is a small vessel disease, and what's the cause of the small vessel disease? If we're looking at small vessel disease, it's important to realize that this is an entity that really goes well beyond just white matter hyperintensities, which although is often the most common radiological stigmata on magnetic resonance imaging, is certainly only as reliable as the company that it keeps. And as Francis has really brilliantly laid out in his talk, small vessel disease in the brain really incorporates many imaging biomarkers. White matter hyperintensity is one of them, in addition to cerebral microbleeds, cortical superficial siderosis, convexity subarachnoid hemorrhage, subcortical infarcts, lacunes, and also cerebral atrophy. And it's really important that white matter hyperintensities are interpreted in the context of all of this company. So white matter hyperintensities certainly don't equal cerebral small vessel disease, and there are plenty of vascular and non-vascular causes. The non-vascular causes which are important include demyelinating and inflammatory causes, such as multiple sclerosis or neurosarcoidosis or other demyelinating conditions, infectious causes, toxic causes, and then the fine print causes, the weird and wonderful, the leukodystrophies, the metabolic leukoencephalopathies, and so forth. And here we have an example of a patient with multiple sclerosis with very clear white matter hyperintensities in a periventricular distribution, which would be typical for that condition. But multiple sclerosis is often something I find is overcalled on many reports, whether using the terms multiple sclerosis or referring to demyelination in a young patient with vague neurological symptoms and perhaps a few white matter hyperintensities here and there. But really, in multiple sclerosis, it's important to realize that white matter hyperintensities occur, although not exclusively, in predetermined regions that are defined by the McDonald criteria. This was most recently revised in 2017 and will have an upcoming revision in the coming months. But really, when regarding the dissemination in space, we're really thinking about three different locations relevant to cerebral small vessel disease, and those being the periventricular regions, the cortical or juxtacortical regions, and then the infratentorium. And really, I think I would impart a warning to perhaps not think about or overcall multiple sclerosis if these particular parts of the brain are not involved in the process that you're seeing on MRI. In addition to cerebral small vessel disease, there are other vascular causes of white matter hyperintensities, and the most common by far would be migraine, with or without aura. But there are others. There's traumatic causes, and there's weird endotheliopathies such as Susac syndrome as well. And here we have an MRI, another flare sequence of a young woman who has a history of migraine with some non-specific white matter hyperintensities. And you can see that in the left hemisphere here that these white matter hyperintensities are subcortical, very distinct from the juxtacortical lesions you might see in someone with multiple sclerosis, for example. And migraine really is an important mimicker from the vascular differential of cerebral small vessel diseases. And the prevalence of these non-specific white matter hyperintensities, often in the subcortical region, are as high as 40% in patients with migraine. And we know that these lesions are present regardless of the age of the patient and their underlying cerebrovascular risk factor profile. The pathogenesis of this is really unclear, but we do know that it is very common. However, it's important to know that migraine and cerebral small vessel disease are not distinct entities necessarily, although they usually are. Migraine can often herald some important monogenic causes of cerebral small vessel disease, which we'll come back to. So in terms of how can we make that unhelpful report a helpful one? So coming back to that 35-year-old with the transient neurological symptoms in the setting of headaches without a past medical history, perhaps we can reword that to there are multiple foci of non-specific T2 flare, white matter hyperintensities. And given the age and the history of recurrent headaches, these are most likely related to migraine. And specifically addressing serious concerns that the patient or the clinician could have, we could say that the pattern is not typical of demyelination and does not meet criteria for dissemination in space. And this really clinically contextualizes the report for the individual patient in front of you, rather than listing a broad list of differentials, which is as non-specific as the differentials are each onto their own. So what if it actually is cerebral small vessel disease? So we previously just talked about causes that weren't, but what if it actually is? And what do we want to know as clinicians? Well, I guess we want to know the severity, and that's particularly important in conditions such as cerebral amyloid angiopathy. But we also want to know the cause, and the cause incorporates the clinical history as much as it does the radiological stigmata. And so when we think about severity of cerebral small vessel disease, and Francis went through these in more detail, but in general we want to know things such as the Physicus grade, because we know that has correlations with cognitive impairment, for example. But more specifically in cerebral amyloid angiopathy, as Francis outlined, we want to know if the cortical superficial siderosis is focal, meaning less than three or less sulci affected, or whether it's disseminated, more than 3 sulci affected. Furthermore, we also want to know how many cerebral microbleeds there are, and the key differentiating number here is 5, so less than 5 or 5 or more. And it's important that we know some of this information because it does actually influence our decision-making. Now, cerebral amyloid angiopathy is a condition where there are really a paucity of robust randomized clinical control trials, but there's plenty of observational data to suggest that the bleeding risk in anticoagulating patients with cerebral amyloid angiopathy and concurrent indicators for anticoagulation, such as atrial fibrillation, that risk can be modified or estimated with some of these radiological biomarkers. So, for example, we know that cortical superficial siderosis, when presenting in a disseminated fashion, actually carries the same almost the same risk of intracranial hemorrhage as a patient who's actually had an intracranial hemorrhage previously, which is quite an enormous risk, whilst cerebral microbleeds carry a much lower risk. And so knowing the severity of the cerebrovascular disease can really help us risk stratify and actually does change what we do in clinical practice. And furthermore, patients actually ask us when we tell them that they've got evidence of small vessel disease and in the stroke or neurology clinic, they want us to quantify that. Is that mild? Is it moderate? Is it severe? We often do use terms like wear and tear and just to make it very simple for the lay person, but they want to really know exactly how much wear and tear there is. And I think they're entitled to that information. The next thing we want to know is the cause of the cerebral small vessel disease. And this is really important in both younger and older patients. And to uncover the unusual and important causes, we have to incorporate the clinical history. And unless you think about it, you won't be able to make the diagnosis. So, for example, in a patient with a possible transient ischemic attack, now, to me, that could mean that the patient's actually had a transient ischemic attack or a minor stroke which is resolved. But often, more commonly, a lot of my emergency colleagues would think that a transient ischemic attack is really a description for any transient episode of neurological or otherwise unexplained symptoms. And as you can imagine, this has as broad a differential as white matter hyperintensity. So it includes migrainous auras, focal seizures, Todd's paresis after a seizure, cerebral amyloid angiopathy in the form of amyloid spells or transient focal neurological episodes, vestibular syndromes, orthostatic syndromes, functional neurological disorders, and really the list goes on. And so I guess if I want to impart one thing when you're looking at an MRI in a patient with a history of TIA is not to work through all of those differentials, because as you probably realize, most of those differentials don't have any any radiological stigmata on MRI. However, one that does are transient focal neurological episodes or amyloid spells in the setting of cerebral amyloid angiopathy. Now, these can be exactly the same as TIAs or can be distinct, typically spreading symptoms, often positive symptoms that spread over the course of seconds to minutes, but can be even more prolonged than that. And these are really characterized by convexity subarachnoid hemorrhage or the residues of such, that being cortical superficial siderosis. So in a patient with a suspected transient ischemic attack, it's important to scroll all the way up to the vertex to look for cortical superficial siderosis. And when present, it's going to be symptomatic in areas that are eloquent and actually would result in neurological dysfunction, such as in the central sulcus or in the occipital lobes. And as mentioned, this is really important to find because these are patients you not want to be starting dual antiplatelet therapy on because they carry such a high risk potentially of intracerebral hemorrhage moving forwards. The other clinical history that I think should just ring alarm bells is the history of migraine. Now, a history of migraine in almost all cases will just mean a history of migraine or a headache disorder, which is not migraine. But the migraine is important because there are lots of cerebral monogenic causes of small vessel disease, which actually have migraine as a very early feature of the disease. And it's important to be aware of this. And these are diseases which I often refer to as the alphabet soup of cerebral small vessel diseases because they're littered with lots of acronyms. So there's CADASIL, there's the COL4A1 or COL4A2 brain small vessel disease, CARASAL, RVCLS, and MELAS, with their full names here for you to read. And to summarize the alphabet soup, because this is a topic, as you can imagine, is well beyond the scope of what could be covered in a few minutes. But these disorders do have their own unique clinical profile, but the common denominator is really that they have a history of migraine, often early on in the disease. And to take the prototypical disease as an example, CADASIL, which is an autosomal dominant condition and one of the more common, if not one of the commonest causes of monogenic cerebral small vessel disease. Migraine is often the first symptom that develops before the stepwise progression to strokes and eventually cognitive impairment and dementia. And each of these cerebral small vessel diseases have their own unique brain MRI features. And so as Francis outlined, CADASIL typically involves the anterior temporal lobes and the external capsules, and cerebral microbleeds might also be present. COL4A1 or call for A2. Brain small vessel disease is typically more a hemorrhagic disease than an ischemic disease, so cerebral microbleeds predominate compared to the white matter hyperintensities. They also have other unusual features such as aneurysms and parenchyphalic cysts. Carousel is exceedingly rare and does not, at the moment, from small numbers of patients, seem to have any unique radiological features. RVCLS is quite a different beast. It can present radiologically with both punctate white matter hyperintensities, which are very nonspecific, but also mass-like lesions, and as its name suggests, can really have a wide variety of clinical features. And then MELAS is our prototypical mitochondrial disorder that causes these stroke-like episodes, migraines, and other neurological symptoms and other metabolic symptoms. And these are typically radiologically have infarcts which cross multiple territories and often have less ADC change than you might expect for a traditional infarct, owing to the different type of edema that's often present. And so incorporating these aspects of the clinical history into our notes with this same 35-year-old with recurrent headaches and transient focal neurological symptoms, perhaps a conclusion could be that there are multiple foci of nonspecific tier 2 flare white matter hyperintensities. Given the patient's age and the history of recurrent headaches, these are most likely related to migraine. But had the scan have showed this, we can often add, however, given the hyperintensities involve the anterior poles of the temporal lobes and the external capsules, CADASIL could also be considered as a unifying diagnosis, knowing that migraine is a common early feature of CADASIL, as mentioned. So really the take-home points from this are that white matter hyperintensities, although the most common feature of cerebral small vessel disease, certainly do not equate to having cerebral small vessel disease. And it's important to distinguish that from other causes of white matter hyperintensities and use the clinical information. That's what it's there for. An assessment of the severity of cerebral small vessel disease is important for clinicians and it's important for patients, and it's particularly important in patients with cerebral amyloid angiopathy. Beware of the referral for transient ischemic attack and be aware of what the referrer could mean may not be what a TIA by definition is. And important to know that cerebral amyloid angiopathy doesn't get missed in your review of an MRI for someone with a potential TIA. Do look for that cortical superficial siderosis or convexity subarachnoid hemorrhage. And finally, be aware that while most migraine is migraine is also a really common cause that's shared between a number of rare but important monogenic cerebral small vessel diseases, in particular CADASIL. And it's important to know that you might be the first person to diagnose this condition because of the changes that you appreciate on MRI, which often are present well before other clinical manifestations that make the disease very apparent to the treating neurologist or other clinician at the bedside. Thank you very much and hope you enjoy the conference.